High-risk surgical patients are individuals who have a significantly increased likelihood of experiencing complications or mortality during or after surgery. This increased risk may be due to pre-existing medical conditions, the complexity of the surgery, or other patient-specific factors. High-risk patients often require careful preoperative assessment, perioperative management, and postoperative monitoring. Common characteristics of high-risk surgical patients. 1. Age. Elderly patients, especially those over 65 years, are at greater risk due to reduced physiological reserve and comorbidities. 2. Comorbidities. Cardiovascular disease, e.g., coronary artery disease, heart failure, respiratory conditions, e.g., chronic obstructive pulmonary disease, renal impairment, e.g., chronic kidney disease, diabetes mellitus, obesity or severe malnutrition, immunosuppression, e.g., cancer, organ transplantation, HIV. 3. Surgical factors. Major surgeries with high complexity, e.g. cardiac, vascular, or abdominal surgeries. Emergency or urgent surgeries where there's limited time for preoperative optimization. Long-duration surgeries, which increase the risk of complications like infections and deep vein thrombosis. 4. Functional status. Limited mobility or dependence on others for daily activities. Frailty, often measured by tools like the Frailty Index. 5. Previous complications. History of anesthesia-related complications or poor recovery from past surgeries. 6. Lifestyle factors. Smoking, heavy alcohol use or drug abuse. Poor adherence to medical advice or treatments. 7. Laboratory and diagnostic findings. Abnormal lab values, e.g. anemia, electrolyte imbalances, imaging findings indicating advanced disease, e.g. tumors near vital organs. High-risk surgical patient involves a comprehensive, multidisciplinary approach to minimize complications and optimize outcomes. Here's a breakdown of considerations and steps. 1. Risk assessment. Medical history. Identify comorbidities such as cardiac, pulmonary, renal, or liver dysfunction, diabetes, obesity, or advanced age. Surgical risk scoring. Use tools like ASA score, American Society of Anesthesiologists, grades overall physical status. Revised Cardiac Risk Index, RCRI, evaluates risk of perioperative cardiac events. APACHE 3, for critically ill patients in the ICU. Functional status, assess MET's metabolic equivalence of task. Patients with 4 METs are higher risk. Frailty scales, assess physical and cognitive function, especially in older patients. Number 2, preoperative optimization, multidisciplinary team. Include surgeons, anesthesiologists, intensivists, and specialists, e.g. cardiology, pulmonology. Cardiac evaluation, stress testing or echocardiography if indicated. Pulmonary optimization, smoking cessation, 4 weeks pre-op. Treat COPD or asthma exacerbations. Incentive spirometry and physical therapy. Nutritional support, address malnutrition or obesity. Blood management, treat anemia or coagulation disorders. Infection control, treat any existing infections and optimize antiseptic protocols. Medication review, continue necessary medications, e.g. beta blockers, statins. Adjust anticoagulants, antiplatelets based on surgical bleeding risk. 3. Intraoperative management. Experienced team, use highly skilled anesthesiologists and surgeons. Hemodynamic monitoring, consider invasive monitoring, e.g. arterial line, central venous pressure, for unstable patients. Minimally invasive techniques, if feasible, prefer laparoscopic or robotic surgery. Anesthesia plan, tailor to minimize cardiopulmonary stress. Regional anesthesia may reduce systemic complications. Fluid management, avoid both under-resuscitation and fluid overload. Blood conservation, minimize intraoperative blood loss and consider cell salvage techniques. Hammer 4, postoperative care. ICU step-down unit, monitor high-risk patients closely. Pain control, use multimodal analgesia to minimize opioids. Early mobilization, prevent complications like deep vein thrombosis, DVT, or pulmonary embolism, PE. Infection prevention, monitor for sepsis and adhere to protocols. Nutritional support, initiate early enteral feeding if possible. Complication monitoring, watch for cardiac events, arrhythmias, myocardial infarction. Pulmonary issues, atelectasis, pneumonia. Wound complications, dehiscence, infection. Acute kidney injury, AKI. 5. Communication and planning. Informed consent, discuss the high risk with the patient and family, including potential complications and alternatives. Palliative care. In some cases, discuss goals of care and consider whether surgery aligns with patient values. This approach ensures a balance between aggressive treatment and thoughtful care, improving outcomes for high-risk surgical patients.